Dr. Pradeep is consultant.
Good afternoon, everyone. So, welcome to the last session. Um there's a ongoing debate amongst the pain physicians between subpedicular and transkambin approaches. What is better? Subpedicular was also known as the safe, quote unquote, safe triangle approach. So the question comes, why was it called so, even though there is a lot of arteries around that point? So the story goes that we were trying to actually access the DRG in order to do CRF, conventional radiofrequency ablation of the DRG. That was the aim, and it's well documented by Dr. Prithviraj in his books. So that is the place where interest towards the subpedicular or the safe triangle approach came in. And of course, Transcambin, we know, is a great place for us to access the intervertebral foramina. So talking about the intervertebral foramina, it's essentially a passageway for us from where we can enter into from where the nerve roots actually exit, and it also gives us a pathway or a sort of a conduit through which we can reach the nerve roots. It's around 19.4 mm in height and around 8.8 mm in width. And this height and width, of course, goes up and down according to the pathology. The roof is marked by the pedicle and the vertebral notch. The floor is marked by the superior vertebral notch and the pedicle itself of the lower vertebra, and the posterior aspect of the vertebral body and the intervertebral disc mark the anterior aspect, and the posterior part of this triangle is marked by the inferior and superior articular processes. So going a bit deeper into the intervertebral foramina, it consists of a large number of ligaments. It has nerve root in it. It has some small vessels and a couple of large vessels as well. So the idea is, if we target the lower portion, we are going the transcambin route, and if we are targeting the upper portion, we are going the subpedicular route. So this is essentially the crux of the whole thing. Um, Regarding the Kambin's triangle, of course, if we zoom in properly, we can find there's an exiting nerve root which forms the hypotenuse of the triangle. There is the ascending SAP of the lower level vertebral body is also which is forming the base of the triangle. So this is what the Kambin triangle looks like, and this is our spot of entry. Safe triangle, not safe, but still the hypotenuse is again formed by the spinal ganglion. There's a triangle which is superiorly marked by the pedicle. As you can see in this slide, this is where the safe triangle essentially lies, and you can see there's a lot of arteries which are traversing this area. So this is what makes the risk of vascular spread quite prevalent in this case. While this is where our usual landing spot for the Kambin's triangle is, and we are, as you can see, able to mitigate most of those vascular complications. Now, this is a coronal section which is revealing the Kambin's triangle again. This small triangular zone is where we are entering from, and if you look closely, you'll see how tiny this working space is, and it's actually just a millimeters of room which gives us access to such important structures. So again, there's another thing that we need to remember is the how the nerve roots are in comparison to the vertebral disc, how steeper and how the bifurcation is happening. So as you can see, as we go down, the nerve roots, the transforaminal area just keeps on becoming narrower and narrower as we reach the L5S1 nerve root. So this is the reason while doing endoscopy, we prefer the interlaminar route at L5S1 while L4, L5 and others, we can still access it very easily using the transforaminal route. And I will actually demonstrate in the video as well. So this is the video that I wanted to show you. First of all, of course, you cranial and caudal tilt. I am fortunate enough to have DSA with me. So you can see very clearly the structures being formed. You can see the SAP, you can see the facets very clearly. Yeah. So this is the pedicle, and this is the Scotty dog which comes up, and this is essentially where your target for a a supraneural approach will lie, and this is where the target for the Kambin's approach will lie. Right. So again, two videos, both of them demonstrating the same thing. Sorry, demonstrating the same thing. Wait. Yep. So you can see this is where the 6 o'clock of the pedicle is where the supraneural approach will lie, while the Kambin approach will lie just lateral to the SAP of the lower vertebrae. So you just enter via the I've entered via the Kambin approach here. I'll just if it just plays. Yeah, you can see the epidural spread in the anterior epidural space going in. And I don't know why I'm not able to play this other video. Right. So there's another way of actually accessing this the transforaminal space via both the Kambin and the supraneural approach. So what you essentially do is you mark a midline, and then you mark the vertebral angle, the discal angle essentially, and you take it laterally from the midline. So this is how the endoscopic approach to the transkambin side actually happens. So we are able to mark a lateral most line from where we start taking the entry. So we are marking the same thing on the patient, and now we enter. Not able to play, excuse me. Yeah, wait. So you can see I am entering in, and finally I'll rest my lever on the SCP, on the facet joint. You can see in the lateral view I've rested it on the facet joint, and then I am going to do a bit of maneuvering in order to slip inside the facet joint. You can actually see in the lateral view the exact point in which I have entered into the space. You can quite clearly see that there. Yep. And finally, when we inject the dye, we get this fluoroscopic picture where both the traversing and the exiting routes are getting, bathed in the contrast. So, yeah. Now, coming on to the, just one final point. Of course, we have discussed there's a lumbar artery which is lying supraneurally, so we have to be very careful. But then there is, an artery called the Desprosian-Gautran artery, which is an anomalous artery which also lies in the Kambin's triangle. And of course, venous anatomy is not very important when we are just doing an injection, but when we start doing transforaminal pelt, it becomes of immense importance. And we just need to remember that the internal vertebral venous layers, they run longitudinal in front of the posterior longitudinal ligament on the ventral surface of the spinal canal. So that is something that we need to remember while we are doing pelt, not during the injection. So take home message is master the anatomy and be secure and safe, and thank you so much.